similarly to how I started, I tend to not look at answer choices. Mike had a really great tip where you can glance at them if you want and kind of just gauge, sort of what the answer choices might be going for. I'm going to try to not look at these, which is a little bit hard. But I'll start with the last sentence. So which of the following likely led to the development of his representation? Okay, so this is a common thing that you'll see a lot in UWorld is, you don't get a lot from this question. I mean, we don't know anything about the disease process. We don't know anything about the organ system at this point. We really have no idea. We know that he's coming back to the hospital or to the office, and we're going to start thinking about why that might be. But this is a little bit less helpful than some of the other questions that we previously looked at. So we're kind of going into this still up at 30,000 feet. We don't really know what we're thinking about quite yet. So we'll jump back up to the top. Okay, so we have a 67-year-old man who's presenting to the emergency department with crushing chest pain. Oh, wow. That's pretty classic for a particular disease process. If anybody wants to pop that into the chat, I won't say anything. We'll come back to that. Oh, love it. So he reports he usually has mild pain after walking 3 blocks, but this has progressed to be present at rest. Okay, boom. So now we're having pain at rest, whereas before it seemed to be some chest pain on exertion. I'm going to try to go through this without saying any diseases, and y'all can jump in. Oh, great. This is lovely. Oh, you're doing so wonderful. He has also had worsening shortness of breath and sputum production over the past 2 years, along with, a 70-pack year smoking history. Wow. Okay, so we have this guy who's been smoking for a lifetime, and he's been having worsening shortness of breath over 2 years. So right now, what are we thinking? We're thinking he has this cardiac issue, and with shortness of breath and sputum production, the sputum production seems like maybe a pulmonary issue. So if we think a little bit back to the question itself, right, representation, okay, maybe he's representing for more of a cardiac issue. Maybe we're going a little bit more towards pulmonary. Excellent. So potentially COPD, potentially chronic bronchitis. Love it. Okay, so he's in the hospital and he's getting an EKG, which indicates a left circumflex ST elevation MI. Perfect. So whoever said MI at the beginning, you can give yourself a pat on the back. Love it. So he's having an ST elevation MI. So he has, he receives a stent and is discharged 2 days later on aspirin, clopidogrel, and propranolol. Okay. So one thing that I always like to do is check myself, and when I see drugs, make sure that I kind of know what class they're in at least, because that may be something that's important, right? Maybe we're going to get a drug-related question here. So aspirin, an antiplatelet, clopidogrel, also an antiplatelet, and propranolol, which is I'll leave it up to you guys. Okay, so the next day, he represents to the emergency department with 2 hours of shortness of breath. Okay, so we're back, shortness of breath for 2 hours. And on this representation, here are his vitals. So he has a temperature of 98.9, heart rate 92, respiratory rate is 22. That's a little bit elevated. And he has a blood pressure of 142 over 91. So elevated blood pressure. And his oxygen saturation is 90%. So that's pretty down. Not super, super dangerous yet, but 90% in a guy with potentially COPD and a very long smoking history, a concerning oxygen saturation. So he has a cardiovascular exam, normal S1 and S2, normal jugular venous pressure. So what does that tell us about what is not causing his current shortness of breath? So if you were perfect. Oh, great. Y'all are awesome. Who's ready to take step 1 tomorrow? I feel like that's a lot. There are a lot of people who are ready to take step 1. Okay. So now we're getting pulmonary exam, demonstrates a prolonged expiratory phase. Okay, awesome. Now we're back to the question. So which of the following likely led to the development of the representation? So as y'all are mentioning, right, this new shortness of breath is really the symptom that I think we're dealing with. And because his cardiac exam is normal, right, or he has a normal S1, normal S2, and no JVD, that tells us that the shortness of breath probably is more related to a pulmonary issue. At least it's not related to heart failure. Okay, so at this point, we could look at the answer choices. For me, I'd like to go back and try to think through, okay, well, what might be going on here? What could be underlying this cause? What's the diagnosis? And so someone had mentioned COPD. A subset of COPD would be chronic bronchitis because of the sputum production. I would also put emphysema on the differential, just because, you generally would think chronic bronchitis with sputum production, but with the 7-year pack-year history of smoking, you could put emphysema on the list too. And then, it doesn't really sound like a restrictive picture, right? It definitely sounds like a obstructive picture because he's having this prolonged expiratory phase. So those are kind of the two things, the two subtypes of COPD that I would have on my differential. And let's see, is there any reason why he might be having worsened COPD symptoms? And I think so. I was looking through the chat. I think somebody probably said this already, but why might he be having worsening COPD symptoms after his MI? And we talked a little. Perfect. Oh, great. So he's been put on a beta blocker, which is great for somebody who's post-MI, but why might this particular beta blocker be an issue? Propranolol, right, is a non-specific beta blocker, and so you can get issues with the pulmonary system. Great. Oh, y'all are killing it. Okay, so we did all of this without looking at the answer choices, or at least I like halfway did. It's really hard without putting a sticky note on my screen. But we can then look at the answer choices. And what I like to do is if you have a really good idea of what the answer choice should be, go and try to find it and then check that box, right? So let's look and see, boom, answer choice E, COPD exacerbation, right? So I would say to my student, if you feel confident about it, you can pick it and move on, right? If you know what's going on, if you feel 100% based on the history and physical and all the information they're giving you that this is a COPD exacerbation, don't second guess yourself by looking at the other answer choices. If you are 100% certain, go with that feeling. If we were to think about some of the other answer choices, and I encourage them to do that on review, you can go and look and see, all right, well, what do these other answer choices look like and why do they not fit? So we can run through these, quickly. So cardiac tamponade, you would pretty much expect there to be a difference in the cardiovascular exam, right? You might have distant heart sounds. You would generally expect there to be JVD, right? Oh, love it. Y'all are killing it. Oh, gosh, you're going to put us out of business. Everybody's doing great. Ventricular arrhythmia, right? Normal S1, S2. So unlikely that his heart is, beating irregularly. Acute decompensated congestive heart failure, right? There's no JVD. So unlikely to be any sort of heart failure. And then stent thrombosis, he's having shortness of breath. He's not having chest pain. I would also expect, again, going back to the JVD, if he's having thrombosis, then he might be experiencing some heart failure as well. And so that could lead to some backup and increase in the pressure within the pulmonary system. And finally, which I think everybody else pointed out, is the prolonged expiratory phase of the pulmonary exam is really, really crucial, right? That's classic for an obstructive pulmonary disease. So y'all did great. So I think we settle on the answer choice E.